Distinguished guests, dear colleagues and friends, first of all, I would like to start by recognizing our panel members, Dr. John Ataguba, Dr. Cesar Victora, Dr. Sana Contractor, Dr. Janet Vega, and Professor Michael Marmot. Thank you so much for joining us today. And of course, to the moderator, Dr. Pascal Alote. As you know, health equity is the theme of World Health Day this year. This is one of the core challenges of our time, which is why we're launching a campaign to build a fairer and healthier world. Inequity is not a new problem, of course, but the COVID-19 pandemic has brought it into sharp focus. More than 2,850,000 of our sisters and brothers have lost their lives, and we have lost them. The hard truth is that some of those people died simply because they could not get the care they needed, because of where they live, or who they are, or how much they earn. The pandemic is not only exposing and exploiting inequalities, it is exacerbating them. COVID-19 pushed an estimated 120 million people into extreme poverty last year. Gender inequalities have significantly increased, with more women than men leaving the labor force. And as we speak, rich countries are vaccinating their populations, while the world's poor watch and wait. Health inequalities are not just unfair. They make the world less safe and less sustainable. So, as countries respond, recover and rebuild, it's vital for all governments to invest in better health and social services and remove the barriers that prevent so many people from using them, so more people have the chance to live healthy lives. This World Health Day, here are 5 things we call on all governments to do to address the inequalities that cause so much suffering every year. First, commit to equitable access to vaccines, tests, treatments, and services for COVID-19 within and between countries. Second, strengthen health information systems and invest in better data to shine a light on inequalities and who is being left behind. Third, protect and prioritize health in budgets, including in stimulus spending and for longer-term recovery plans. Fourth, deliver equitable access to services and infrastructure to ensure safe, healthy, and inclusive neighborhoods in both urban and rural areas. And fifth, strengthen primary health care as the foundation of universal health coverage. This World Health Day, we're calling on all people to raise their voice and for a fairer, healthier world. This series of webinars features some of the top experts on health equity from around the world. They will discuss concrete tools to improve the way we measure and reduce inequality in communities and countries. I again thank the speakers who I just named earlier when I started my speech for joining us, and all of the participants everywhere in the world for your shared commitment to build back better from the COVID-19 crisis to ensure a healthier, fairer world for all. Now, I would like to introduce our moderator, Professor Pascal Alote. Professor Alote is the director of the United Nations University International Institute for Global Health. She is also a midwife and public health nurse and an expert in the health aspects of equity, human rights, gender, and community engagement, among many other areas. Professor, you have the floor.
Thank you very much, Dr. Tedros, and a very happy 73rd birthday to the World Health Organization. While these are somber times, we do owe it to ourselves to take pause to acknowledge and celebrate what has been accomplished so that we do not lose the lessons from what has worked well. Distinguished guests, colleagues, ladies and gentlemen, good evening from the United Nations University International Institute for Global Health in Kuala Lumpur. And thank you for logging into this live streaming of an urgent call to work together to tackle health inequities. Please join the conversation by posting your questions in the Q&A feature, and we'll reserve some time towards the end to try to address them. Ladies and gentlemen, COVID-19 has illuminated and magnified health inequities. Based on current socioeconomic analyses, inequalities are predicted to increase in the future, further threatening health equity and the right to health for all persons. I would be hard-pressed to identify any aspect of our lives that has not been affected in some way by the pandemic. A few have buffers to reduce the impact of the shock. Many do not. The devastation and need for recovery provides an opportunity to do this, not just by patching up broken pieces together, but by really examining the structures to redefine an architecture that is resilient, ethical, and fair. This has to be the ethos behind building back better. So it's incredibly refreshing to see, hear, and engage with an increasing number of policy dialogues that give priority to the principles and values underpinned by social justice, equity, and human rights. It's therefore a great privilege to introduce the eminent panel of speakers to address how inequities are being magnified in this current COVID-19 context, what is needed to change this, and how to build back to a healthier, fairer world. Our panelists have incredible bios, and I will tell you a little bit about each of them before their interventions. They will each have 5 minutes, strictly 5 minutes, to open up, and then we can start a discussion. So first up, we have Associate Professor John Ataguba, who is the Director of the Health Economics Unit at the University of Cape Town. John has significant experience in several sub-Saharan African countries and was the interim South African Research Chair in Health and Wealth. He was also the Mellon Mandela Fellow at Harvard University and received the T.W. Kambule NSTF Award, which is the Oscar Award for Science and Research in South Africa. John, could you speak to us, please, about the costs of inequities to society, the economic and social multiplier effects of addressing them through investments in health for all, and the need to take action? John, the mic is yours.
Good. Good afternoon, colleagues. Good morning, good evening, depending on where you are. It's my pleasure to be here, and I want to first of all thank the organizers for having me as a panelist. I also want to recognize the presence of the Director General of the WHO and all of my panel members here. And of course, every other person listening, all protocols duly observed. It's important to note basically that inequalities have what I call a life course dimension. It multiplies through into adulthood because we know health is like a form of capital that can appreciate or depreciate over time. So therefore, the impact of health, for example, at a very young age can still perpetuate into adulthood and of course begin to affect employment opportunities, income generating opportunities, etc., going into adulthood. So therefore, the need to take a life course approach to addressing health inequalities is very evident. And it's even more evident in the context of the COVID-19 pandemic, especially because the pandemic targets vulnerable population groups that range from little children to the very elderly. Again, health inequalities are widening within countries and between countries over time. And this has been exacerbated by the COVID-19 pandemic. Unfortunately, health inequalities affect the poor more than the affluent within countries and between countries. We've increasingly seen that, that poorer countries and people who are poor tend to have severe health outcomes compared to the rich. And this also applies to what we call the social determinants of health inequalities. The COVID pandemic has heightened this, like I said, between within countries, and we are also seeing that with the rollout of vaccines. Poorer countries are either left behind or are left at the tail of the distribution. So the so-called gradient is still perpetuating itself in every ramification, including the rollout of vaccines, and the Director General of the WHO also highlighted that. There are costs associated with health inequalities, obviously, and the COVID-19 pandemic exacerbates that, the costs. We know the costs that can be associated with health inequalities can be what economists call macro or micro costs. The micro costs are costs that affect individuals, firms, or even government directly. For example, anything that affects income generation capacity of individuals or employment capacity of individuals, or how individuals are able to flourish, have what we call the micro costs. We have seen increasingly in many countries globally that the onset of the COVID-19 pandemic affected education of children, it affected income generation of households, especially female households, female-headed households. We know in Africa, for example, over 70% of those who work in the informal economy are women. And the implication of this is the COVID-19 pandemic has really made things difficult for such families, and many families stayed without income, apart from countries where governments are able to provide income relief. Macro impacts of health inequalities that have been caused through the COVID-19 pandemic include dampening of economic growth. If you know, basically economic growth is aggregating all incomes in the economy. So it begins from individuals to firms and also governments to how countries interact between countries in terms of trade. And unfortunately, during the COVID-19 pandemic, trade was heavily impacted. So many countries suffered significantly in that regard. Also, there are costs that are associated with health inequalities that the vulnerable groups suffer significantly. And lastly, to end, there are short-term responses that have been used for COVID-19 pandemic, but I would add that we need more permanent solutions to address this. The greatest challenge many countries face is the lack of preparedness. Many countries have weak and unprepared health systems. Although you need more than the health system to address health inequalities, the health system itself impacts and helps in attenuating health inequalities substantially. And we should not forget, lastly, the importance of the role of the social determinants of health in attenuating health inequalities and the impact that health inequalities will have on society, and of course, the cost of health inequalities. Thank you.
Thank you very much, John. We'll go straight to the second speaker. Cesar Victora is Emeritus Professor of Epidemiology at the Federal University of Pelotas in Brazil. where he leads the International Center for Equity in Health. Since the 1980s, he has conducted research in maternal and child health and nutrition, birth cohort studies, inequalities in health, and on the evaluation of major health programs in many countries. Cesar was a founding member of the Countdown to 2015 Maternal, Newborn, and Child Health Initiative, and remains as one of the leaders to the Countdown to 2030. He won the Canada Gardner Global Health Award in 2017, and in 2018, 2019, and 2020 was included in the Claret Web of Science list for the world's highly cited scientists. Cesar will speak about the importance of collecting disaggregated health data and health inequality monitoring. Cesar, you have the mic.
Many thanks, Pascal. Good morning, afternoon, evening, everyone. It's a real pleasure to be here on the World Health Day to speak about disaggregated statistics, which is my main field of work. I'm speaking as the head of the WHO PAHO Collaborating Center on Health Equity Monitor. And I just wanted to start giving you a little bit of history. The MDGs were very successful in many ways, but they completely ignored equity. They were all based on national averages. So if a country reached a 2/3 reduction in under 5 mortality, the country had reached the MDG, regardless of whether some population groups were left behind. Starting in 2003, I was a founding member, as Pascal just mentioned, of the Countdown to 2015, which monitored the MDGs at country level with a focus on equity and on accountability. The SDGs made a lot of difference. There are important changes. The motto of the SDGs is leave no one behind. So intrinsically, this is an equity related goal. SDG 17.18 specifically mentions the need to increase the availability of high quality, timely, and reliable data disaggregated by income, gender, race, etc. So there's a specific SDG on data disaggregation. Having said that, SDG 3 does have an equity goal because it mentions ensuring healthy lives and promoting well-being for all at all ages. So there's a notion of equity, of reaching everyone, but none of the health goals or indicators specifically address equity. If we look at the SDG 4 indicators for education, they do much better than the health educations. The overarching goal is to ensure inclusive and equitable quality education for all. And each of the goals calls for disaggregated statistics by wealth quintile, by sex of the child or adult, by urban rural residents, and so on. So I think there's some way we can go ahead with the health goals, in which we should not only ask, for example, the SDG on under 5 mortality, which is to lower under 5 mortality to under 25 deaths per 1,000. That should not only be for a country as a whole, but we should add that we need to lower the level of mortality for boys and girls, for the poorest quintile, for rural areas, for all ethnic groups, and so on. Right now, we do have quite a lot on disaggregated statistics. We're doing much better than we did in the MDG era. We have the Countdown to 2030, country equity profiles, which are produced by my group here in Pelotas. We also work closely with the WHO Health Equity Monitor. UNICEF and World Bank produce a large number of disaggregated statistics. Traditional disaggregation is done by sex, urban-rural residents, wealth quintiles, and education. But we need to do better. We need to address more systematically the disaggregation by ethnicity, by religion, by migratory status, disability, and so on. For example, how can we address structural racism if we don't document, monitor, and act upon all the ethnic group inequalities, which are present in all countries? We think of ethnic groups inequalities often in terms of developed high-income countries where there are minorities, but in all of our countries, there are different ethnic groups and they do have different levels of health status. Therefore, it's absolutely essential to focus on ethnicity. What are the gaps and challenges right now? I think the number one is that we don't have a lot of data on adolescents, on adults, particularly on adult men and elderly persons. A lot of our surveys cover children and they do cover women of reproductive age, but there are huge gaps on what we know at a global level on inequalities in the health of adolescents, men, and elderly people. The other challenge is how to incorporate equity dimension in routine administrative data. Surveys are relatively easy to do, to incorporate equity dimensions, but not necessarily administrative data. I will end up with a single example. We did a nationwide surveys in Brazil for COVID seroprevalence. We found that indigenous populations have 5 times higher seroprevalence of antibodies against SARS-CoV-2. We found that Black and brown individuals, as classified by Brazil ethnic group classification, they had twice as much as whites. So 5 times more for indigenous, twice as much for whites. Needless to say, our government did not like the results on indigenous populations and cut the funding for the surveys, but that's one challenge we have to be to face. When we're studying inequalities, there are some groups who may be upset by the findings we have, and we have to stand by the necessity, the need to continue these studies. My take-home message is that disaggregated statistics are essential for eliminating inequalities in health. Thank you very much.
Thank you very much for that, Cesar. Our third panelist, to just move quickly straight on, is Dr. Sana Contractor, who is a public health researcher and practitioner, currently an independent consultant based in India, an alumnus of the Emerging Voices Fellowship. She has been engaged in research and action on accountability for health rights for the last 15 years. Her work has focused on equity in health, including, but not limited to, the axis of gender. Sana is convener of the Sexual and Reproductive Health Hub of Community of Practitioners of Accountability in Health, led from the Global South, a member of the Accountability Working Group at the WHO Partnership for Maternal, Newborn and Child Health, and a member of WHO's Community of Practice on Social Accountability. Sana will be speaking about building trust and accountability between health systems and communities to make progress towards health equity in recovering from this crisis. Sana, please, the next 5 minutes are yours.
Thank you, Pascal, and the WHO for this opportunity to speak at this important panel. This talk draws on my work with various colleagues at COPASA, especially Jashodhara Das Gupta and Marta Schaaf. What I'm going to speak about today builds on Cesar's very important intervention about the critical need for disaggregated data and measurement. And while the data tells us something about who's being left behind, equally, if not more important, it is the aspect of understanding the stories behind the numbers. And the MDGs and SDGs have propelled us, as he explained, to examine inequities more closely. And that has been extremely valuable. But they also present this temptation to want to improve the numbers, if you will. And various sorts of policy shifts aren't always in line with the principles of equity. And in fact, some policies may even make things worse for the most marginalized. So as one of my mentors used to say, when your car isn't moving, instead of pushing harder on the accelerator, sometimes one must open the bonnet and see what is going on. And this means examining how and why inequities are produced. We know that political and historical processes that are rooted in unequal power distribution across nations, genders, social and economic groups. These processes oftentimes lie outside of the health systems and at times are perpetuated by health systems themselves. I chose to focus today on trust and accountability because in times of the pandemic, I think these have been severely damaged. The pandemic has required people to give up some of their most cherished rights in the interest of a greater good. This is standard public health practice to curtail the spread of a highly infectious virus, but it has also altered state-society relationships, with the state holding more power and therefore more responsibility. This means that there's a greater than usual imperative for the state to tackle. In reality, however, this has not always happened. Public systems have crumbled, safety nets are absent, and in several parts of the world, violence has been used against citizens while enforcing lockdowns. The social contract, therefore, between people and the state,
The speaker is not clear. It is difficult to render the interpretation.
The public health system unable to cope with both COVID and non-COVID care. In India, for instance, despite the health ministry's efforts to curtail profiteering in the pandemic, the private health sector behaved in ways that were unethical and at times predatory. Healthcare providers have also not been immune to these prevailing biases against stigmatized communities. At the same time, the past year has also made it amply clear that if a pandemic has to be curtailed effectively, the participation of communities is critical. Despite the encouraging strides that have been made both in COVID treatments and vaccine development, the success of the pandemic response still depends heavily on how people behave, including their acceptance of vaccination. What this requires, therefore, is confidence-building measures, transparency, and a guarantee of accountability from the health system. The success of building back better, therefore, I think, does not lie in top-down directives, but through collaboration, solidarity, and mutual respect and accountability between communities and health systems. So I propose 3 things that the health systems can do to reinforce trust and accountability. The first is to involve communities, not in a tokenistic or instrumental way, but in a meaningful and respectful way. During the pandemic, community health workers and communities themselves have mobilized, sometimes spontaneously, to fill the gap left by state inaction, which has put an unfair burden on them. But now it is time to not just leverage community resources, but to also listen and respond to their concerns by co-creating efforts to build back better. This is especially true for marginalized communities who have faced stigma, discrimination, and also those who suffered disproportionately due to the pandemic control measures. Second, institutionalize and strengthen accountability mechanisms. In order for people to trust the health system, accountability measures need to be instituted and respected. And this is not just true for public health systems, but even more so for private health systems, especially where they are unregulated. And finally, to conclude, I think the most important thing that we need to do is repair the social contract. The pandemic has provided opportunities to reimagine a relationship between communities and health systems that builds on resilience and solidarities. And this means providing spaces for civic engagement, rights claiming, and a commitment to transparency and inclusiveness. This effort of the health sector, of course, must take place alongside the larger action across sectors if it is to be meaningful. But I think as a site of care and healing, we are suitably poised to make a start. Thank you.
I'm sorry, but that sound quality was not sufficient for interpretation.
Jeanette Vega Morales, who is the Chief Medical and Innovation Officer at Red de Salud, which is a combination of the Catholic University and Cristas, the main private health provider in Chile. She's been in that position since 2018. Jeanette has over 20 years of experience in international health with expertise in the social determinants of health, health equity, and health systems. Jeanette was director of equity and social determinants of health in WHO from 2003 to 2007, vice minister of health in Chile from 2008 to 2010, managing director of health, Rockefeller Foundation, and director of the National Health Fund of Chile. Over the years, she has collaborated in several international advisory committees and boards with multiple international...
Could the moderator ask the speaker to slow down for the benefit of interpreters, please? Could the moderator ask the speaker to slow down for the benefit of interpreters, please?
Ensure involvement of civil society stakeholders and movements in developing solutions to counter health inequities, including the role of digital technologies. Over to you.
Thank you, Pascal, and good morning, good afternoon, and good evening to everyone. The COVID-19 pandemic has exposed the weaknesses in the world's infection surveillance and response capabilities, weaknesses that have persisted over the last several years. Many countries, including some thought to have strong response capabilities, failed to detect or respond to the early signs of the COVID-19 pandemic. They started to fight the virus's spread after transmission was well established. Once they did mobilize, some nations struggled to ramp up public communications, testing, contact tracing, critical care capacity, and other strategies for containment. Ill-defined or overlapping roles at various levels of government or between the public and private sectors have resulted in delayed actions and have worsened the death toll and economic damage. One of the crucial lessons from this pandemic is that governments should be open and transparent to the public. Transparency is directly related to public trust and success in the fight against COVID-19. Governments that have been more successful in responding to the COVID-19 pandemic have been actively communicating with citizens to increase their awareness and engagement of anti-COVID measures. These governments have provided all the most important information, including up-to-date statistics of infected cases and fatality rate, as well as details of the movement path of each individual infected. Unfortunately, in other countries, the pandemic response have largely involved governments telling communities what to do, with minimal community input, even though communities, particularly those that are most vulnerable and marginalized, can identify solutions. They know what knowledge and rumors are circulating. They can provide insight into structural barriers, and they are well placed to work with others from their communities to devise collective responses. Such community participation matters because unpopular measures like low compliance with communities on site leaders are far more likely together to come up with innovative, tailored solutions that meet the full range of needs of their citizens in their countries and then accelerate the path to recovery. In these very unstable scenarios where countries are undergoing rapid and far-reaching changes, the broadest possible range of communication and insight is needed. It is crucial to understand, for instance, the additional needs of vulnerable groups and the lived experiences of difficulties caused by government restrictions. We know, for example, that lockdown can increase domestic violence, that rights and access to contraception, abortion, and safe childbirth care risk is being undermined, and that responses, if not delivered with equity, can create the unpalatable impression that the value of each individual's life is being ranked differently according to their socioeconomic status. From the transition out of lockdown, the terms of the economic stimulus, the provision of digital access to social protection, to the mechanisms to ensure a fair and equitable distribution of COVID-19 vaccines, decisions taken by leaders of the world and countries will have consequences that will be felt for many years and decades for their citizens. They have the moral responsibility to ensure that citizens that will be affected by these decisions are heard and actively participate. In the short term, in scrutinizing the decision being made concerning the pandemic response, including vaccination and determining the transition out of lockdown and other social distancing measures. In the medium term, in shaping the future vision of their societies after COVID-19, including the post-pandemic economic stimulus and social contract, and in the long term, in learning the lessons from COVID-19, holding decision makers to account and taking the necessary decisions to prevent a similar crisis in the future. COVID-19 has devastated and disrupted our world. It has forced us to rethink our definition of normal. The pandemic, however, also offers an opportunity to mend the often adversarial citizen-state relationship. What better time than now to include all voices in creating a new normal, one in which we all have a say? Thanks.
Thank you, Jeanette. That was excellent. Thank you. And last, but most definitely not least, Sir Michael Marmot has been Professor of Epidemiology at the University College London since 1985. He is advisor to the WHO Director General on Social Determinants of Health and has led research groups on health inequalities for nearly 50 years, including as chair of the Global Commission on Social Determinants of Health and subsequent commissions on social determinants, equity, and health inequalities in the WHO Americas, European, and Eastern Mediterranean regions. The report of the EMRO Commission was launched just last week on the 31st of March. And in 2020, Professor Marmot conducted the Build Back Fairer, the COVID-19 Marmot Review. He is the recipient of numerous awards, including the WHO Global Hero Award, the Prince Mahidol Award for Public Health in 2015, 18 honorary doctorates, and was knighted by Her Majesty the Queen for services to epidemiology and the understanding of health inequalities. So Michael, could you speak about the need to build on the COVID-19 response in order to catalyze action and call on governments to follow through on their commitments? The mic is yours.
Thank you very much, and it's a pleasure to join this panel. As you said in the introduction, I've chaired 4 commissions now on social determinants of health globally, the global one, European, the Americas, and now EMRO. And the theme of our EMRO commission was do something, do more, do better. We said that social determinants of health are relevant to all countries, whatever level of income or social and economic development. Do something, do more, do better. And the impact of COVID-19 has been dramatic, as the Director General said, in exposing the underlying inequalities in society and amplifying them. Where we have data from countries, we can see that the inequalities in mortality from COVID-19 look rather similar to the inequalities in mortality from all causes. So addressing inequalities in COVID-19 means addressing health equity. Fundamental. And we called my last 2 reports, the English one and the EMRO Commission report, Build Back Fairer, not just build back better, but we want fairer societies to improve health for everybody. We do not want to go back to the status quo of where we were before the pandemic. And I think there's some lessons we can learn. The first is that as I look across these different commission reports from different regions of the world, there's a great deal we can learn from each other. How countries apply that learning will, of course, be specific to the country or even to cities and regions within countries, but the general learning is global. We can learn from each other. So the first message of the pandemic, the first lesson, is global cooperation, and the scientists have been brilliant. The politicians, less so. WHO has played a vital role in trying to foster global cooperation, but as the DG said, you only have to look at what's happened with vaccines to say that global cooperation was wanting. The second lesson is when we examine what's happened in countries, we realize that we need, as Jeanette said, better quality of governance. The quality of governance is vital. Second, the level of inequalities is hugely important. Third, the message about the importance of public services. The dominant paradigm of the last few years has been leave everything to the market. The lesson of the pandemic is that won't work. The public sector is absolutely vital. That doesn't downplay the role of the private sector. Look at the role of the private sector in developing vaccines. Absolutely vital. But the public sector is vitally important. The next message is that it's not health versus the economy. It's not that we should give priority to public health and forget about the economy, or give priority to the economy and society and forget about the public health. Those countries that have managed the pandemic better have had less hit to their economy. Taking the firm, decisive, social action necessary to manage the pandemic means that the economic and social costs have been less. Are we ready to learn those lessons? I would hope so. We've heard about the importance of access to health care and health services, but we need access to the conditions in which people are born, grow, live, work, and age, and equity in power, money, and resources, the social determinants of health. And to build back fairer, we have to put equity of health and well-being at the heart of all policies. Thank you.
Thank you very much, Sir Michael, and thank you all of the panelists. What's clear is from all of your interventions that we have moved health squarely into a political arena, whether it's about how we engage with communities, whether it's about the ways in which the politicians need to respond with issues of accountability, how we use data, and recognizing that data is politicized as well. We have a lot of questions coming through at the moment, but what I would like us to do in the first instance, please, is just address some questions, and I will ask a couple of you, but if you do want to, any of the panelists, if you do want to respond, just drop me a note and I'll call on you as well. So one of the questions is, why have health and social systems overall performed so poorly with respect to equity during the pandemic, despite our attention to equity for some time? As I think you have all mentioned, that this is not, the issues aren't new. Could I get a response, please, from John, Cesar, and Michael? If I can repeat the question, why do you think health systems have still not performed as well as they can? These are not new issues that we've talked about. What do we need to really be able to push the agenda forward? John first, please.
Thank you very much, Pascal, for that question. I kind of alluded to it a bit when I talked. One of the reasons is I will talk from a developing country perspective, because I know a lot about developing countries and maybe less with developed economies, is the lack of preparedness. Many health systems in Africa and many developing countries are built to be reactionary. They are not built to be prepared for emergencies. So when emergencies hit, for example, the Ebola, and of course, recently the COVID-19 pandemic, they react. So for a health system to be resilient, that health system should not be a reactionary health system. It should be a health system that is prepared to be resilient for emergencies. That's the reason why the health system is there. There is something we say in economics, which is called the option demand. It's basically about the fact that any health system or any hospital should be available, not necessarily because someone is going to use it, but because there is a possibility that someone will use it. So a health system is valued for its option demand property. Unfortunately, many African countries don't value that option demand. I would stop it. Thanks.
Great, thank you very much. Cesar, please.
Yes, that's a really good question. I think the issue is that although we scientists and we public health practitioners give so much attention to equity in general, this message has not really reached our governments to the extent that it should have had. So we do pay attention to equity, we do report on equity, but action is still way behind, as Michael has just said. I think another issue is that there are structural determinants of inequalities in health that the pandemic cannot address adequately in the short term. So the ethnic differences, the poor health status among the poor, the fact that the poor live in crowded homes with insufficient water supply to wash their hands, that they can't afford adequate food, and they are most susceptible to the economic effects of the pandemic because they are in the informal labor market. So all of these conditions, the underlying conditions, the social determinants of health upon which the pandemic has hit, it would be unavoidable to have the sort of gaps that we see between rich and poor. The poor families in Brazil have 2.5 more higher seroprevalence of COVID antibodies than the rich because they were hit by COVID most strongly. Therefore, the important is that as we impose measures such as lockdown and social distancing, we do have to, at the same time, impose very strong programs to meet the needs of the poor population who will be left behind unless we have a proactive redistribution scheme and cash transfers and so on. So the performance in most countries has been pretty bad. I'm afraid that the COVID pandemic, as Jeanette just said, is only exacerbating a very negative situation regarding social determinants of health that we had to face prior to the onset of the pandemic. Thank you.
Great, thank you. Michael?
My guess is that if you look at the health system in Japan, in Hong Kong, in South Korea, in New Zealand, they've not been stressed by the pandemic because the countries handled the pandemic so well. One of the reasons the health systems have been under threat is because countries have not handled the pandemic well. And I'm with Cesar here. The social system is vital. I mean, in our EMRO Commission report, we produced data that pre-pandemic, the projection was that the number of people in extreme poverty, less than $1.90 a day, was predicted to go down in 2020 and 2021. Now, with the pandemic, the number of people in extreme poverty will go up. There was just absolutely no margin for error. And if you look both at what's happened, let's take employment. Some sectors of the economy have closed down, and it's those sectors that employed poorer people, so they've lost their jobs, or they had to go out to work and be exposed to the virus without adequate PPE, personal protective equipment, and then come home to overcrowded conditions and be exposed to the virus. So we can't look at what happened to health systems alone. We have to look at the socioeconomic context in which health systems operate. And countries have been very close to the margin before the pandemic struck. And then with the pandemic, it exposes that countries had no flexibility, with big inequalities, with disinvestment in the public sector. Many countries were simply not equipped.
Great, thank you very much. Sana, you wanted to make some comments as well?
Yeah, I wanted to add also that I think we say this again and again, we've said this after the Ebola pandemic as well, that despite all of the investment, especially over the last 20, 25 years into the health sector with the MDGs and SDGs, what has happened is in a sort of counterintuitive way, there's been further verticalization of the kind of programs that our governments implement, as well as how scientists do research. So I agree that scientists are perhaps a step ahead, but I do think that there's a great deal of specialization that happens without realizing that all of these sectors are linked to each other. And I think we have to take some responsibility for our own contributions in not promoting a system strengthening approach, but rather one that tries to address certain health problems depending on what is seen as the priority, and that priority seems to change. But at the end of the day, whether it's Ebola or it's say this all the time, that these inequities existed, but why have we not done anything about them? So I think when we move ahead, this is a good time for us to also accept that fact that it is no longer okay for us to answer what seem like the easier questions or create what we think are targets that can be met, but rather to question the connectedness of all of these structural factors that produce inequities.
Great, thank you very much for that. Jeanette, if I can come to you to start off on the next question. How can we ensure that this crisis leads to a response that fundamentally transforms society? We really should have an opportunity now to make a lasting difference, not just patch things up. What do you think needs to be done?
Thank you, Pascal. I think that the pandemic has unveiled that the way that we are organizing our world doesn't work anymore. I think that it has unveiled several things that we were saying for several years, but in fact, we were not listening to. For example, that health is absolutely critical if we want to have economic or social progress. And that is one of the main lessons of this pandemic. So if we want to rebuild, I think that it's extremely important that we redefine the social contracts in our nations. We have to go out from this very individualistic society and come back to some of the values that shaped our life before, I would say, before this era of individualisms. I don't think it will be possible to rebuild our countries unless we understand that health is something that affects everyone, everywhere, and that in order to create societies that flourish, we really need to understand and come back to values such as solidarity, such as equity, such as go back to this individualistic approach, and in particular, make sure that our citizens can have the social protection they need with a focus in the most vulnerable of the societies. I think that's the huge lesson of the pandemic. And of course, the other lesson is that we are all connected across the world, and that nobody will be able to get out of this unless we all get out together.
Great, thank you, Jeanette. That was really helpful. Would any of the other panelists also like to comment on that, please? The question was, what do we need to do? We need to make sure that this is that there is a real transformation, not just a patchwork. Any takers on that? Can I?
Well, if I might.
Yes, please.
I'm thinking about politics in countries that I know well, and I think the message is we need not just the politicians to engage, we need civil society to engage, we need the public voice. The politicians will be most unusual if they act without feeling the pressure from the public. And I can see it in my own country. We need to hear the public voice. I think it's absolutely vital. And to get the political change that's needed, I like the way the Thais talk about it. We need knowledge, academia, we need people, and we need politicians. And we need all three of them to be working together.
Great, thank you. If I can draw on some of your interventions from the first round, where you there were several interventions on that talked about data. Cesar in particular talked about the importance of data. Sana talked about the stories behind the numbers and so on. And it's clear that data has been politicized significantly, or it can be politicized significantly. Can you comment, and again, open, but I might start with Cesar first, and then Sana and the others as well. Again, commenting on the importance of data and how to make sure that that it can still be used and can be used effectively towards making change. Cesar, please.
Thank you, Pascal. There was also a question from Bruno in the chat box, which I'd like to address, which is the issue of ethnicity. I think of all the dimensions of equity that I have been working with for 40 plus years, ethnicity is the most sensitive one. We published a paper last year on under 5 mortality. We had data from 36 countries. We found that 25 of the 36 had significant differences between ethnic groups. And I'm not talking about whites and African descent, African Americans in the US, or UK and Asian minorities and so on. I'm talking about countries throughout the developing world, low and middle income countries. 25 of them had significant differences. The average difference in a meta-analysis was 3.3 times higher mortality in one ethnic group, the highest one, compared to the lowest group. That's a lot. That's over 200% excess of deaths in one group compared to others. And what I have seen is that we face, as scientists, we face difficulties in, number one, getting governments to collect data that are disaggregated by ethnicity. And number two, once we have results, in disseminating these results. I mentioned the Brazil study. We found a 5 times higher seroprevalence for the coronavirus in the indigenous population compared to whites. The government didn't like the fundings. They discontinued the funding for our study. But yet, I think we went to the press and we had a lot of coverage for these findings. And it resulted that we're now the 4th Minister of Health since COVID started in Brazil. It's a high turnover job. But the current minister is now prioritizing the vaccination of the indigenous population. So they are, along with health workers and with the elderly, they are the priority groups for vaccination coverage. So I think data can make a difference. Obviously, we still have much lower coverage in African Brazilians than we have in whites. So that has yet to be addressed. But the power of data and getting the data to the people, not only through scientific journals, but through the mass media, will empower different ethnic groups to fight for their rights in a more effective way. So I think data has a lot of power. Data alone doesn't change the world, but it can start a chain of events that will result in permanent change. Thank you.
Great, thank you. Sana, did you want to comment on that as well? And then Jeanette and John as well.
Yeah, I agree. I think it's not just the scientific journals who need to be the recipients of what data is saying, but also people at large. And that, I think, is a big gap at the moment about not just how data is used, but also how data is produced and what are the questions that we ask of it. And I think scientists are in a good position because we are seen as driven by science rather than politics, although that might be a naive thing to say. But evidence by itself, I mean, we also have to accept that some of the changes that have happened, some of the disinvestment in the public health system, so on and so forth, these policy moves have also been taken based on some kind of evidence. So I think there is a role for scientists to be more bold and more brave in what kind of evidence they produce. And I definitely want to also add that there is at present a privileging of quantitative over other kinds of evidence, or systematically, large surveys and so on and so forth. And there is an inherent inequity in who can conduct those surveys and who produces that sort of information. But the stories, and I say that again, are as important as what the numbers say. And I think there is the need for much more legitimacy to be given to that sort of information, and for us as practitioners as well as researchers to start asking questions that lie behind those numbers.
Great, thank you. Jeanette, please.
Yes, I'd like to add that I do see with a big worry what is happening in the I could call it a bit of manipulation of data from some governments. I mean, data in this pandemic has been used as a political tool, and this is extremely worrisome because, in fact, we need the data in particular to make sure that the decisions we are taking are timely and also are universal. And I do think that scientists have a big role to play, in particular in this era where we don't really need papers necessarily. What we need is that the evidence is out there as quickly as possible. That is, for example, the case in our countries in Latin America. And I could say, for example, the issue that we know in my country, that Brazil basically has a new variant, that is the P1, has led us to basically make sure and push that we do have genetic surveillance ASAP, because we know that if we don't have it, we won't be able to take adequate measures to this new variant, if we don't know if the variant is here. And I do think that that has been possible because some of our scientists have put that in the public eye. So I think there is a role for scientists in this pandemic that is far more broader than it has used to be generally. Over.
Thank you very much. And John, as well, you had some comments on this point?
Yes, thanks so much. I think I concur with what others have just said. I want to add that we need to begin to let people know that data belong to the people. And the moment we realize that data belong to people, not to a certain group of individuals who are privy to it, we can change things. Unfortunately, many countries don't internalize that. I've worked in some countries where we've mentioned data are really politicized. One big challenge with data in Africa that I'm very familiar with is timeliness. You can imagine you having data for 2014 now or 2018 today. Of what use are the data? These are things that we need to begin to think of. Unfortunately, again, infrastructure, data infrastructure in many countries, developing countries, we have very poor data infrastructure. So how do we build infrastructure that collects timely data in such a way that they are kind of interoperable for timely decision making. We need decisions to happen as we collect in our data. And remember, data belong to people. And lastly, I would hammer that we need to use community members. We need to marry community members like Michael talked about, marry community members, politicians, and of course, researchers or general public in such a way that we can use community members to influence policymakers or politicians through effective communication using data. So we have data, we report to community and let the community take action and hold accountable people who they've elected to either provide a service or to address the common problem they're facing. I would like to end. Thank you.
Great, thank you very much. Now I'm going to try and combine a number of issues and link it to the question that the issue that we've just discussed, which is with the disaggregation of data, we get to identify communities that are most marginalized, for instance. So the question specifically on the LGBTQI communities and so on. How do we support? What would be the advice, for instance, for you to organizations like WHO or to member states and governments and so on about how to use this effort and this opportunity to actually begin to target population groups that are politically difficult to reach? I know we've talked. It's easier in some ways to be able to identify some of the communities that may be marginalized by geography and so on. That's a different issue, but we know that there are also politically marginalized communities. How do we make sure that they become a part of this effort? What would your advice be? And I will start that off with Jeanette.
Yeah, I do think that that's a big challenge. To have data, first of all, to have disaggregated data is a challenge by itself. And secondly, to have disaggregated data from communities that are usually silent or marginalized is even harder. And I do think that that is another responsibility that we have and the researchers have, is that they need to look for data from those communities. Those communities are usually excluded, are even excluded from help from, for example, let me put an example. Migrant populations. Migrant populations are usually invisible in countries. They are invisible because they are afraid that if they go and try to get some help, they could be expelled from countries, for example. So what we have then is that we have these pockets of population that we don't get any data and that we cannot take actions, and that they are the ones that are living in overcrowded spaces and living in very bad conditions. So they are in fact expanding the disease. So this is an issue that is not only for the sake of the marginalized communities. This is a public health issue. We need to gain data from excluded communities because those communities are the ones that probably will be keeping the pandemic going, and we need to take actions on that to make sure that the rest of the population as well, even if it is only for that and not for from a human rights perspective, only from a public health perspective, we need to make sure that we address the needs of those excluded population. And in order to do that, we need to understand and know what's going on with them.
Great, thank you. Sir Michael?
Thank you. I think the SDGs potentially give WHO a lever. I think very few countries have said they don't want to be part of the SDGs. They've signed up to it. But how can you implement the SDGs unless you have measurement to know how you're doing? So it's not just marginalized and excluded communities, it's in general. For example, when we were doing both the PAHO, the Commission in the Americas, and the EMRO Commission, I gave an example of the report, the Build Back Fair report, and before that, our 10 years on review in England, I'm able to be quite critical of what's happened in my own country. Well, firstly, because I'm allowed to. I'm allowed to speak out and be critical. That's part of our political culture. So the political culture that allows scientists to speak up and be critical of the government is really very important. And so I'm blessed to be allowed to do that. But second, we have very good data. So I can document the regressive nature of government policy, the cuts in government funding to poorer areas. The poorer the area, the steeper the cuts. When I presented some of these data to our colleagues in the Eastern Mediterranean region, they wrung their hands and said, we have no data like this. We don't even have data on disaggregated on health for adults. We used under 5 mortality and infant mortality that comes from elsewhere, but they don't even have inequities in health for adults, let alone inequities in the impact of government policy on social determinants of health. Now, all of the relevant social determinants pretty much are included in the SDGs. So that is the opportunity for WHO to work with countries and say, if you're serious about the SDGs, you need to put monitoring frameworks in place to look at those 17 goals and what you're doing. And hey presto, you will then have a monitoring system to look at health equity and equity in the social determinants of health. And part of that will be looking at migrants, at refugees, at LGBT, at other marginalized and excluded communities.
Great, thank you very much. Cesar, could you comment as well, please? I think you had some interventions in the beginning that would be relevant to this.
Yes, absolutely. I think we in the health field need to learn a bit from the education field. As I mentioned in my opening comments, our indicators for the SDG, the health indicators, mention health for all. Obviously, health for all requires eliminating inequalities. But I don't think that's enough. I think that's too generic. I think we need indicators, and let me just cite one indicator here. SDG 4 for education, indicator 451, parity indices of female, male, rural, urban, bottom to top wealth quintile, etc., in all education outcomes. So they do have specific mention of the need for indicators. And following up on that, we need targets. We need equity sensitive targets. The Pan American Health Organization has gone some way in tailoring the SDG indicators to say no country should have a difference in under 5 mortality or more than 10 per thousand between rural and urban areas, and so on. Rural and urban ethnic groups, rich and poor, and so on. So we can do better. I think there's a great work being done at WHO on the Health Equity Monitor, which provides disaggregated statistics. My group in Brazil provides a lot of the data that is in the WHO website. But we have to move beyond the reporting statistics to having concrete goals. You know, people have to be allowed to know about the magnitude of the gaps and that there are specific goals for reducing these gaps. We're no longer happy with the MDG target of reaching a certain under 5 mortality rate for the country as a whole. That's not enough. We need to make sure that the communities that Jeanette just referred to, that the issues that Michael has just mentioned, that we do address specific, we do determine specific targets for different subgroups of the population. Thank you.
Thank you very much. John, you had a few comments as well that you had wanted to make on this topic?
Yes, thank you very much. I again concur with what colleagues have said. I just have one thing to add in this regard, is that in many cases, we lose out something that I think it was Sana that mentioned it, the qualitative aspect that we cannot capture. I'll give an example. I've worked in a country like Sierra Leone in Africa. Now, Sierra Leone is a country with a very high proportion of women who've attained at least 4 ANC visits, one of the highest on the continent. Unfortunately, that country suffers gravely in terms of maternal mortality. We are very much aware that many other factors, the determinants of health, the social determinants of health, play hugely in determining a maternal mortality beyond use of ANC or even delivery by a trained assistant. However, looking at these key statistics, even though you disaggregate them, you will not get to the heart of the fact that there are so many things that drive these that are qualitative that we may not be able to capture. So it's also important beyond disaggregation, which I don't disagree with, but we need to also go deeper to understand why some statistics are the way they are. Cultural factors could be determining them. So it's something to layer upon disaggregation. Thank you.
Thank you very much. Sana, I'll come to you in a second, but just before, I'm just keeping an eye on the time. After Sana's response, I'd like you all to think about your quick fire 1 minute take-home message that you want to leave with everybody. But we can't finish this conversation without at least making some link to the vaccine equity issues as well. Sana, can I take your response on this, and then I'll make the vaccine question a bit clearer. Sana, please.
Yeah, I also wanted to add that it's data is not the only way to address inequities, although I recognize that it's a starting point, it's important and so on. But there are community organizations who work with groups who are marginalized, who have an insight into their problems and issues. And I think it would benefit the World Health Organization to consult and confer with those groups. It of course, it deeply is dependent on the status of the groups within countries themselves, how criminalized they are, how much marginalization there is, and stigmatization. But to my understanding, groups do, even if they are marginalized groups, criminalized and criminalized as per law, etc., there are always community organizations, even if not formal ones. And so I would urge us to look at and to reach out to those groups, if not directly to countries themselves.
Thank you very much for that. So our final round of questions, if you can start off, please, by just commenting on your take on the vaccine equity issues, whether you think your intervention is about the global inter-country or intra-country issues. I'd really like to hear your take on where we are at the moment with vaccine equity, but also then give us your critical take-home messages. And I will start in the order that we started with John, please.
Thank you again. It's been an absolute pleasure to talk about this. In terms of vaccine equity, we very much aware that Africa and many other developing countries lag behind. And it's also fair to add that in terms of the burden of coronavirus disease, basically, Africa has not had that very large number of deaths compared to very developed countries. So when one analyzes equity issues, it's important to layer on top of that need, whether it is perceived need or current existing needs. So that said, however, the current vaccine distribution is globally dismal. In terms of Africa, I speak for a lot, we need to begin to think of producing vaccines locally rather than depending so much on importation. We've got very excellent scientists. So these are the kind of challenges we're talking about. Let's not blame others for our challenges, but also take proactive steps to contribute to the development of vaccines on the continent. And I assume that's one of the ways to address equity challenge. To add the last word in terms of my take-home message, health inequalities have really amplified by the COVID-19 pandemic. And that has perpetuated, of course, inequalities generally, including health inequalities with multiply effects that go beyond the health sector. That affect, for example, income generation, education, employment, and economic justice. So if there's nothing else you want to take home from me, just know that this is a very important message that we need to know in terms of how health inequality transcends just the health sector, but touches on many, many other sectors. Thank you.
Thank you very much, John. Cesar, please.
Thank you. I think vaccine equity or vaccine inequity, it reflects underlying inequalities in the strength of health systems and the concentration of wealth and power throughout the world. So it's not a surprise. Vaccine nationalism is not a surprise. The fact that some countries have several times the number of doses required for the population, and they're holding this excess number of doses in their own countries rather than distributing it through say COVAX facility, it's not a surprise. That's the way the world has worked so far. It can be addressed, of course. I think COVAX is a great example of an attempt to distribute vaccine to those who need it most. But unfortunately, as I mentioned, it's just the way the world works so far, and it does we badly need a new world global economic order to counteract this kind of vaccine nationalism, which will occur again and again with the next pandemics that will come along. My closing statements are, number one, that data are an essential tool for advocacy and for empowerment. If we can document that some communities, some ethnic groups, some social classes are being left behind, it will allow action to bottom-up action to occur. It will contribute to bottom-up action to address the underlying structural inequalities that we all face. And the last point that I want to make is that there's a lot of opportunities that are missed. We speak about missed opportunities for vaccination. Yes, a kid comes to a health facility and doesn't get a vaccine that he should get, but there are lots of missed opportunities for producing disaggregated data. Many surveys, many administrative data systems, health information systems in most countries of the world do provide opportunity for documenting and monitoring inequalities. And we often, as scientists and as public health practitioners, we often miss such opportunities. Lastly, disaggregated statistics are an essential early step for eliminating inequality in health. They're not sufficient, but they're necessary. Thank you.
Thank you very much. Sana, please.
On the question of vaccines, I come from a country that is a vaccine producer and is also a drug producer. So I think I have to agree with John's intervention that I think there's an increasing need for us to invest in our own R&D and our own production. In India as well, we actually do have public sector capacity to produce these vaccines, which we are not utilizing, and it has entirely been done by the private sector at this point. But I think it makes sense to go back and rethink that, since we do have a very robust public sector manufacturing capacity, both for drugs and vaccines. And I think that is part of equity as well. The other thing that stands out for me with vaccines is the very poor level of transparency with respect to the trials as well as the sort of black and white way in which the discourse around vaccines has taken place. It's almost as if you are for the vaccine or against the vaccine, and we aren't allowed to ask any questions about why somebody had an adverse reaction or why a certain adverse reaction or what seemed like an adverse reaction was not related to the vaccine. And I think these sort of barrier in building trust, and they will not serve us well in the long run. And so because this is new technology, I think as scientists, we also have a responsibility to be more transparent and to engage with citizens at large about what these trials mean and what these adverse events mean. And I think that will bring down the fear substantially. My takeaway point for this session would be, I think we need to focus on repairing the social contract. And I think that underlies our relationships with health systems. It seems like something beyond our control because it does indeed have intergenerational, historical, political roots. But I think the health sector is in a unique position. It is seen as a neutral actor that is responsible for caregiving and healing. And I think if nothing else, no matter how large this task seems or how challenging it seems, I think it's our responsibility to make a start. I'll stop there.
Fantastic. Thank you very much. Can I move to you, Janet, please?
Yes, sure. I'm conscious of the time, so I'm going to be very short. I think that related to vaccines, the only point I want to make is that agreeing with everything that everyone is saying, we have to make sure that vaccines are not the final response. And my country is an example of that. We do have more vaccines than what we need. However, we are still in a growing epidemic. And the reason of that is that we need to put in place the population-based measures. Trace, isolate, and testing is crucial, as well as taking the quarantines and everything that we need. But in order to do that, we need to make sure that we support our citizens and our vulnerable citizens to be able to, in fact, be without work, for example, the informal workers, and be at home and take the measures of containment that we need to take at the same time that we are vaccinating. My takeaway message is that I do agree strongly with what has been said before. We need to revisit the social contract in terms of our globally and in countries, but also we need to think about what type of development we want to have, what type of society we want to build, global society, and also societies in our countries to be to go back to what we used to be in terms of solidarity and inclusiveness. Thank you.
Fantastic. And finally, Sir Michael.
Well, your question about vaccines prompts me to think about three comments. The first is that we should want global distribution of vaccines for, in turn, three reasons. One is the moral one. If vaccines save lives, then the right thing to do is to save lives, and that means global distribution. The second is the economic one. For rich countries, if they want to trade with countries and the world economy is being hit by the persistence of the pandemic, they should want to do something about it for their own economic interests. And thirdly, their health interests. The mantra that no one's safe till everyone is safe, it should be in the interest of vaccine-producing countries to spread it. My second point is the one that Cesar made, which is what's happened to the vaccine is an indicator of global inequities. It was utterly predictable that this would happen. And my third point, and that's really my take-home message, and it's underscoring what Jeanette just said, that nobody thinks that once we've got the vaccine, inequalities in COVID-19 will go away, or inequalities in health will go away. We'll go back to where we were with great health inequities. So my take-home message, once again, is to put equity of health and well-being at the heart of all policy, globally, nationally, and subnationally.
Fantastic. Thank you, all of you, for a lovely, lovely discussion. One of the things that I'm so excited about is that this is an event that is hosted by WHO, and it is a real acknowledgement that health is politics, and that we are really going to have to engage. I think in a lot of countries prior to this, health was always the poorer ministry, not the more powerful one. I think health has a space, it has certainly taken center stage as part of the management of the pandemic. And the fact that we are having this discussion that focuses on equity centrally for World Health Day is an amazing development. And very clearly, all of your interventions really emphasize the need to move into the social and the political space in order to really make a difference, to engage communities, to re-engage the social contract, and to be bold and brave in representing the knowledge and the research and so on that is based on the data that we collect into making a change for our communities. I'd like to sincerely thank the panelists. I'd like to thank the interpreters who have done a stellar job. I often forgot to talk slowly. I'm pretty confident that they managed to keep up nonetheless. So thank you very much. You make sure that the message is put out. I'd like to thank the equity and rights, I believe, section, gender equity and rights section of WHO for organizing this. Have a lovely World Health Day, the rest of you, and thank you again to all of the panel. Thank you very much.